Title of today's podcast is Till Everybody Got Delirious, Geriatric Patients in the Emergency Department. And our guest skeptic is Dr. Christina Shenvi. She's a board-certified emergency physician, educator, keynote speaker, coach, and academic leader. She is widely regarded for her work in geriatric emergency medicine, faculty development, and professional identity formation in emergency medicine. She brings a deep clinical expertise along with a thoughtful perspective on system-level change and guideline development. Welcome back to the SGEM, Christina.
Ken, it's always a pleasure to be here and be a little bit skeptical of everything.
Well, we get to do this back to back because last week we did an SGEM Extra together on the Geriatric Emergency Department Guidelines 2.0. And that was important for two big reasons. And I'm going to go through those two big reasons. The one reason, we now have an updated Geriatric Emergency Department guideline, and it's been updated from 2014. So 12 years jumping forward. But then the second big thing that came out of that podcast is you have a really good singing voice.
Well, I don't know if that can be replicated. We'll see. That might have been an N of one.
An N of one study. But you are the karaoke queen to me now.
Oh, well, thank you.
You're welcome.
My enthusiasm for karaoke is not always matched by my skill at singing. We'll leave it there.
Just because I can't dance doesn't mean I won't dance. And just because somebody can't sing doesn't mean they won't sing and make up for it with enthusiasm. Enthusiasm. And this is a real natural progression from the previous episode, because now, going from, hey, they've got these new guidelines, 2.0, updated recently, and now we're actually going to go through one of the new guidelines using the guidelines to develop guidelines. So I think this is great. So why don't you give us a case?
Very meta. Yes. So this Delirium guideline is the first one that's created, and they're planning a whole slew of 6 or 7 of them that are coming out.
6 or 7? Did you just say 6 or 7? You're so hip.
7. I'm sorry. I apologize. But this is a really practical one, and it makes sense that this is the first one that they came out with because delirium is so important in the ED. You can imagine this patient that you saw on your last shift, an 82-year-old woman with hearing impairment, some mild baseline dementia, who's brought into the ED by her daughter because she became, just not acting herself over the last day. She's more sleepy. Maybe she then becomes a little, we call it agitated, or some behavioral disturbances, or keeps losing the thread of conversation. Maybe the nurse or physician has her try to say the months backwards and she gets lost. You can imagine she comes in by ambulance from home after nearly falling. And now she has a fever and some mild tachycardia. The daughter reports foul-smelling urine and poor PO intake for what that's worth. And on exam, there's nothing really focal. There's no focal neurodeficits, no signs of head trauma. And so then in the ED, we're wondering, well, is she just confused? Does she have delirium? How do we confirm if she has delirium? And then also, does she need a head CT as part of the workup if she does have delirium?
Side note, does anybody ever come in saying, you know what? This urine really smells good. It's got a nice nose on it or something.
Yes.
Like, a sommelier or whatever they're called. I guess it'd be a sommelier. A sommelier versus a sommelier. Yeah, I've never heard anybody say, the urine really, it had a really nice fruity
fragrance.
Anyways, delirium is an acute brain dysfunction, and it's a disturbance in attention, squirrel, and awareness that develop over hours to days. It can fluctuate, and it's accompanied by additional cognitive disturbances, like you mentioned, something like memory or language problems, orientation, or perceptual changes. And in older adults, it is common, dangerous, and often goes unnoticed. The latest Geriatric Emergency Department delirium guidelines indicate that delirium occurs in about, you ready for this, 6 to 38% of older ED patients. So like a third of the patients potentially that we see can have some delirium going on. It increases mortality, contributes to functional decline, and imposes a significant burden on the healthcare system. ED-based geriatric screening tools also highlight that delirium is frequently under-recognized by us. working in the emergency department, and that hypoactive delirium is most common, making bedside detection even more challenging.
Absolutely. And, whenever I see big ranges of numbers like that, like delirium between 6 and 38%, that's a pretty big range. That tells me that there's not great data out there, or the studies are very heterogeneous. And you mentioned specifically hypoactive delirium. So I want to just backtrack to give people some I struggle with this word because I was raised in British English and I call it nomenclature. And then people say, no, it's nomenclature. In any case, the nomenclature around this is there's hypoactive delirium, which is the most common subtype, which is the patient is just kind of sleepy, not really engaging. Hyperactive delirium is where they're agitated, picking at things, climbing out of bed, etc. And then the third subtype is mixed delirium, where they may fluctuate between the two states. But hypoactive is far and away the most common. And for emergency physicians, delirium really matters because it's rarely the only diagnosis. It's usually a clue that there's something else going on. There's an underlying infection or dehydration or hyponatremia. And so it's important to identify the delirium and then look for precipitants. Sometimes the precipitants can be environmental. They were moved to a new living situation, or they lost sleep for a night because they were in the ED. But one reason that the new guideline is useful is that it's really honest about the evidence gap. There are prior reviews that have looked at this and found there's no consistent ED-based strategy to prevent incident delirium or treat prevalent delirium. So when we talk about prevalent delirium, that means delirium that the patient comes in with, whereas incident delirium is delirium that the patient gets while in the ED or the hospital. So this guideline focuses on the parts of care for which there is enough evidence to guide decisions. But I have to say, I really hope that there will be some good studies on preventing delirium in the ED, because ultimately that's what matters. We can identify it all day long, but where there is no remedy, there should be no regard, quoting Lady Macbeth. So in any case, hopefully we can then get a remedy.
You're a Renaissance woman. You're quoting Macbeth. You're singing Alanis Morissette songs. Oh, yeah, this is good. This delirium guideline is also notable because, mentioned earlier, it was built using those geriatric emergency department 2.0 model for subspecialty guideline development. And the geriatric emergency department initiative moved beyond the older consensus 2014 framework where everybody just sat around and go, hey, Christina, what do you do for this? I don't know. What do you do for this, Chris Carpenter? I don't know. What do you do for this? Right? So it's not consensus based, and it has this transparent process of using the grade criteria. It brought in a whole bunch of people from various disciplines to work together. It explicitly used the PICO, so the population, the intervention, control, and outcome questions, systematic reviews and meta-analysis, evidence decision frameworks, attention to feasibility, equity, stakeholder value, plus external stakeholder value. So really a comprehensive update. Now in this SGEM Extra, we'll highlight this first EM subspecialty guideline effort to fully adopt grade. And this delirium guideline shows that process in action. So let's go. What's the clinical questions they were asking?
Well, they had 3 PICO questions here for this clinical practice guideline. First is, which older ED adults are at highest risk on walking in for delirium? And I think the motivation here is that it's time intensive to screen everyone for delirium or to implement prevention measures for everyone. So which are the highest risk patients? That's what their first question. The second question is, okay, let's say we want to screen certain patients or all patients for delirium. Which tools should we use to identify delirium in the ED? And then third, should that acutely confused or delirious older ED patient undergo a head CT as part of a routine delirium evaluation?
So you're setting your radar for the first thing on who's at the highest risk, and then which tool should we use to see if that person who's at high risk is really having delirium, and then do we have to send them to the donut of truth and scan their head?
Yes.
Right? Those are the
correct.
3 things? Okay. So what's the reference? Who wrote this?
This was by a team of people who are writing the new geriatric ED guidelines, but it's Lee et al. the grade-based clinical practice guidelines for ED delirium risk stratification, screening, and brain imaging in older adults with suspected delirium.
Wow, they went to the Rick Bucata School of Title Writing because they get the grade thing in there, emergency department, risk stratification. So who are you going to risk stratify for high risk? Who are you going to screen? What tool are you going to use? And are you going to scan these people's heads? So it's all right there in the title, people. I'll give you the conclusion. I'll spill the candy dish at the front door here. They concluded rigorous ED-based research is needed to strengthen evidence and guide delirium care for older adults in geriatric emergency medicine. End of quotes.
Which is a little bit of a wah-wah, which I kind of wish that there were better evidence so that the conclusion weren't, we need more research. However, that said, I think there's still a lot that the practice guideline can bring forward.
Maybe we'll see this surge in research funding for geriatric emergency medicine, just like we did for some of the other things that baby boomers got, right? So we were looking at cancer and it got lots of attention. We looked at cardiac, right? Cardiac care, that got lots of attention. Looked at joint replacement, those types of things. Well, maybe we'll move on to this whole idea of geriatrics. And just, and again, as a side, thanks to pickleball, that's been a huge influx in injuries from people over the age of 65. It is just, the baby boomers are going crazy for pickleball and the number of injuries I'm seeing. This is off the topic of delirium. So let's go through the quality checklists for guidelines. So the first question to you, Christina, the study population included or focused on those in the emergency department?
Yes, it did. Check, check. It is explicitly about older adults presenting to the ED.
Speaking of explicit, an explicit and sensible process was used to identify, select, and combine the evidence.
Ken, this process was so explicit and so sensible that it required an entire SGEM extra episode. So listen to last week's episode because we went through it.
You could have just said Chris Carpenter was involved in it. You would know that it was very good methodologically, right? The quality of the evidence was explicitly assessed using a validated instrument.
Yes, they used the grade framework that we talked about last time, and Agree To was used to review the trustworthiness of the evidence.
An explicit and sensible process was used to value the relative importance of different outcomes.
Yep, the group got together, selected those 3 PICO questions, and then looked through values, preferences, feasibility, equity, harms, costs, etc., in order to pick the right questions.
Yeah, really holistic, right? And involving patients about their preferences and values. The guideline thoughtfully balanced desirable and undesirable effects.
Yes, this is built into both the GED model and the delirium guidelines use of the grade frameworks.
And the guidelines account for important recent developments.
Yes, the GED 2.0 guidelines was specifically created to update the 2014 consensus guideline using newer evidence or lack of evidence where available.
The guideline has been peer-reviewed and tested.
Well, it is published in a peer-reviewed journal, so clearly it underwent external stakeholder review, but we don't have necessarily prospective real-world field testing of the recommendations, but I don't know that that's too much of a downside because it's all based on evidence that has undergone thorough review.
Practical, actionable, and clinically important recommendations are made.
Yes, they make recommendations about specific bedside choices of risk stratification, tools to use, and who needs a head CT.
And the guideline authors' conflicts of interest are fully reported, transparent, and unlikely to sway the recommendations.
I can't say 100% on this one, but they did disclose any conflicts, and this was adjudicated by impartial grade experts, which is reassuring. So I don't see a whole lot of likelihood of any financial incentives swaying evidence here.
All right, so let's talk about the key recommendations. They came up with 6. This is upsetting to me because couldn't they have combined one of them or 2 of them together just to come up with 5, my favorite number? But no, they had to extend it to 6 to make it complicated for me. So they came up with 6 recommendations that are conditional, and they all rest on very low certainty of evidence. And as you said before, wah, wah. And I'll put a table in the show notes that puts those 6 things into a table for you to review. But let's talk about them because they broke it up into those 3 things, right? Risk stratification was the first thing.
So risk stratification, they said their recommendation was to use the Delirium risk score to identify low-risk older ED patients who may not require further delirium screening. And their recommendation was 4, but the certainty of evidence or quality of evidence was very low. So just as background for the listeners, the delirium risk score includes 3 things, 3 factors. Does the patient have underlying dementia, difficulty with their activities of daily living, and there's a score for that, and hearing impairment? And if you have none of those, there's less than 1% chance that you have delirium on arrival. If you have all 3 of those, then it's close to 50%. So if you are able to screen everybody, maybe even with an AI or EMR tool that will tell you, does this patient have baseline dementia, difficulty with their ADLs, and hearing impairment? If they have none of those, then you can be pretty certain that they are at low risk for delirium. If they have, 1 or 2, then that risk will go up. So that could be a quick way to screen patients to then focus your more involved assessments on higher risk patients. Another recommendation that they made, and these are kind of a buffet of options. You mentioned it was 6 recommendations. You wouldn't necessarily use all of them all at once. You would pick one from column A, one from column B type of thing. So that first one was for all comers to the ED. And the next one is for patients admitted to ED observation. And this was using this tool called Zucchelli's screening tool, which looks at, are they age 75 and over? You get 2 points for that. Do you have dementia? 3 points for that. Hearing impairment, 2 points. And have you received psychotropic drugs? 1 point. And so if you have a score of 4 or more, that's considered high risk. So again, the whole purpose of this is to understand who's high risk for delirium in order to then do more screening on them or implement preventative measures. So if you're going to ED obs, you could use the Zucchelli's tool.
And then for patients greater than 75 years of age in the ED, they also had a risk stratification for those patients.
Yes, and this one, I didn't like this one as much, to be honest. So the third risk stratification tool that they gave is called REDEEM, and it stands for Recognizing Delirium in Geriatric Emergency Medicine. And it's based off of a paper from 2021 where they looked at patients age 75 and older coming to the ED who were screened for delirium and then did a regression analysis to create a model with, get this, Ken, 10 variables.
Ugh, I need an app for that.
I know. I'm sorry, but 10 variables, that's too many for me. And I think that it just makes it harder to implement. And some of them can be pulled from the EMR, like it's your respiratory rate, your diastolic, systolic blood pressure, your vitals, etc. But then history of seizure disorder, that might be harder to pull depending on your EMR. And the whole purpose of this risk stratification is to then, in their paper, is to then say who needs assessment for delirium. Now, the assessment for delirium can be done with other tools, which we'll get to next, like the BCAM or the 4AT. Those tools are faster than the REDEEM tool. So I don't know that I see this particularly being that useful.
So you don't see very many redeeming qualities in this tool.
You could say that.
You got the first dad joke in, so I had to get a second dad joke in. But yeah, that leads us to the sort of whole diagnostic tools. And you mentioned a couple of them, but there are like a half dozen of them. And I'll put links in the show notes. And some of them do go to MD Calc. So it'll be available in your smartphone. You can just pull up MD Calc and do one of these things. And they may be used to rule delirium in or out. But again, these are conditional, again, based on very low certainty of evidence.
Yes. And I think the conditionality is, the low evidence is recommending them as a practice guideline. The tools themselves are very well validated and have been used in many, many sites internationally to screen for delirium. So the tools themselves, I think, are quite good. The ones, so there are various diagnostic tools to identify delirium. Some places just screen everyone. 65 and over, you're automatically screened. Or you could do it with first assessing for high-risk people. The tools that I think are most useful, one is kind of a twofer. It's doing the delirium triage screen, which is very quick, can be done at triage, and it helps rule out. So it's very sensitive. So it'll tell you, all right, this person not concerned about delirium. If your DTS is positive, then you want to follow it up with a BCAM, the Brief Confusion Assessment Method. And that looks at, do they have acute or fluctuating course? You have to ask the patient or the family. Do they have inattention? Like you ask them to do the months of the year backwards and they can't do it. Altered level of consciousness or disorganized thinking. So you ask them something like, will a stone float in water? And if they're disorganized thinking, they won't be able to answer that. So if you have a positive BCAM, that is very specific. So that rules you in for delirium. So that combo of the delirium triage screen, which just looks at, do they have a abnormal RAS or altered level of consciousness and attention? So it's positive DTS and positive BCAM, you're ruled in for delirium. That's one great combo. Another option is called the 4AT, and this is used internationally. And that looks at, number one, your alertness. And then number two, it's kind of like a tool within a tool. It's like very Inception. Number two is the AMT, which is the abbreviated mental test for orientation, which is where you have them tell you their age, date of birth, location, and the year. So one is alertness, two is the AMT, those four things. Three is attention. You have them do the months of the year backwards. And four is acute change or fluctuating course. So honestly, it's really similar to the BCAM. And then if you have a score of 0, it's normal. If you have a score of 1 to 3, errors, possible cognitive impairment, 4 or more, possible delirium or severe cognitive impairment. So all of those tools are great for identifying the presence of delirium, whether you do it on all comers or just those who have high risk based on their baseline features.
All right, so that goes through the diagnostic tools, but what about advanced imaging? This is the brain imaging. We mentioned this earlier. Do we do the emergency medicine alphabet, A, B, C, T? Do we send them and get a CT scan of their head if we think we need to rule out delirium, but we need to scan their head?
Well, their conclusion, sadly, was that in the undifferentiated older ED patient with delirium or altered mental status, there are insufficient data to recommend for or against a head CT. So another kind of, oh well, too bad, very low certainty. And I think if there's clear signs of trauma, then it makes sense. Or if there's a history of trauma, or they were found on the floor, found down, or a witnessed fall, then it makes total sense to get some head imaging. Beyond that, there isn't good data to recommend one way or the other.
So those are the three questions they were asking about: risk stratification, which tool should we use, and then getting a CT scan of their head. Let's talk a little nerdy about these guidelines. Are you ready to talk nerdy to me, Christina?
Ken, talk nerdy to me.
Oh, I love it when people say talk nerdy to me, because I love talking nerdy. I mean, really, other people have, like habits, like, they like to go golfing, they like painting, they like karaokeing like you do. But for me, it's talking nerdy. This is what gets me up in the morning. I love talking nerdy. And the biggest thing in this guideline, and we've mentioned it multiple times, is about the certainty of the evidence that underlines these recommendations. The guideline authors are admirably transparent about the fact that every recommendation is conditional and based on very low certainty evidence. In grade terms, this means the true effect may be substantially different from the estimate, especially when the evidence is downgraded for risk of bias, indirectedness, inconsistency, and imprecision. And that matters because even a methodologically really rigorous guideline, like you can have great guidelines, but if the underlying data isn't great, that's what you're stuck with. And that's what you're stuck with. So even though you have people like Chris Carpenter on there making sure that you're checking off all the boxes and doing all the right things from a methodologic standpoint of putting together a guideline, you're still left with the ingredients going into that guideline.
Yep. Like we said last time, even if Chris Carpenter is there cranking the handle, if you have bad meat in, you get bad sausage out.
Yeah.
So another challenge is external validity. And a second threat is that a lot of the evidence comes from single center diagnostic or prognostic studies that maybe don't have as much external validation. Now, I will say some of the things, like I mentioned, the screening tools, those have been well studied and validated in a lot of different places. But it does note, the paper does note that the risk stratification tools were supported by single center evidence and in most cases didn't have separate validation research. So from an evidence-based diagnosis perspective, that raises concerns about spectrum effects and transportability, meaning, okay, it worked in one site, but if we move to another site with a different case mix, different population, maybe different language, will it perform differently?
Yeah, and we see this a lot of the times with clinical decision tools that are attempted to be tried. And, they may work very well in a derivation set. They may be validated. But then once you get outside the area where it was validated and you go to, into the wild, shall we say, they perform differently. And how they perform is still an open question. And this gets us to the third nerdy point. And this was about biases. Diagnostic test studies are particularly vulnerable to recognizable biases such as spectrum bias, incorporation bias, and verification bias, and finally, the imperfect gold standard bias. And I'll put a link into the best paper, and of course, Chris Carpenter's on that paper, but it's by Khan. And I say something like that today, and residents just don't understand that was from Star Trek, Wrath of Khan, the second movie, the best movie out there. Anyways, I'll put a link in the show notes if people really want to get into diagnostic studies and biases. But it's not a theoretical problem here. Delirium has no perfect ED criterion. Patient severity varies substantially, and some studies may include more selected populations than the real world of undifferentiated older patients that might come wandering into your triage unit. And the diagnostic bias literature emphasizes that these biases can systematically exaggerate or underestimate the sensitivity and specificity.
Absolutely. And then another challenge is patient-oriented outcomes.
Oh, I was just going to see if you would say it.
Poo.
It's about the poo.
It's about the poo. So many of the recommendation driving outcomes are diagnostic accuracy or likelihood ratio outcomes rather than patient-oriented outcomes. So yes, we want to know how well can we screen or identify this or that. But then what the patient cares about is, am I going to get better? And it's understandable that we don't yet have patient-level outcomes because the ED delirium literature hasn't really identified a consistent intervention that clearly improves those downstream outcomes. That's the ultimate goal, truly. But it does mean that the chain from better screening to better patient outcomes remains partially assumed rather than proven. It's all well and good to say, great, we can identify delirium, but then does that actually lead to patients having better outcomes, shorter lengths of stay, better functional improvement, or, discharging to home rather than to a facility?
Yeah. And so we need that whole chain. If you can't identify the patients that are at high risk, you're missing people. And then if you can't diagnose them with good screening tools, then you're not doing. And if you don't have a good intervention to mitigate against the delirium, then you're actually, where along that chain. But you've got to do good. You got to do good. You got to do well at each of those chain links to get that good poo at the end, that patient-oriented outcome, instead of all of these surrogate outcomes, or SUs, as I like to call them. All right, and the final thing is, what about the thresholds? The guideline authors deliberately relaxed their likelihood ratio thresholds for including tools, noting that conventional thresholds would likely have excluded every delirium prognostic and diagnostic instrument from the guideline. That is a pragmatic and defensible choice, so they could defend this in a sparse evidence-based, but it also introduces a degree of arbitrariness into the tool of what makes the cut. In other words, the recommendations are built partially on methodologic compromises designed to keep the field moving forward rather than on clearly overwhelming bodies of evidence to say, aha, thou shalt, we have the answer. And unfortunately, we don't. But that you could also frame that as, hey, there's a great opportunity. If you're listening to this podcast and interested in doing research, the field it's a target-rich environment right now.
Mm-hmm. Absolutely. And I think you have to balance accuracy and perfection against pragmatism. We have to sometimes say, all right, what do we have? What's the best that we have? And how can we make it work? Because if we wait for everything to be perfect, we'll be waiting a whole long time.
Yeah, and that's the whole, what is it? Perfect is the enemy of good, right? And so incremental improvements. All right, how about an SGEM bottom line?
Well, the bottom line, Ken, this guideline provides EM docs with a good roadmap for delirium risk stratification, meaning who's at high risk for it, bedside diagnosis, what tools should we use, and then selective imaging. However, the signal is useful only if we keep our skeptical radar set to high because the underlying evidence is still very shaky.
You like how I slipped in that skeptical radar, didn't you? All right, how about you resolve that case of that 82-year-old patient that presented?
Well, the 82-year-old patient that I described is exactly the kind of patient who should trigger us to think about delirium. She's older, she came in by ambulance, she has baseline dementia and hearing impairment. In my mind, like all the bells are going off that she is at super high risk. If she doesn't have delirium right now, she's probably going to get it while she's in the ED if she's there for a long time. And now we're told she has acute fluctuating change in attention and awareness, all features that raise concern. At the bedside, we could use a validated ED tool like the 4AT or the DTS with the BCAM rather than just Gestalt alone. If she screens positive, we should then look for underlying causes and treat them, and also use non-pharmacologic supports to try to help her not escalate in her behavioral disturbances or agitation. So things like making sure she's not interrupted while she's sleeping, not using tethers, not interrupting her with vital signs every 5 minutes, turning beeping noises off in the room, giving her food and water if she doesn't have a reason to be NPO, helping her to the bathroom, getting her mobilized to a chair, keeping the lights on during the day, normalizing homeostasis. It's all of those little things that add up to make a big difference. And then because she has no signs of trauma or focal deficits, we definitely don't need to, the guidelines don't force us to get a routine head CT. Instead, it really says there's just insufficient evidence to recommend for or against. And the absence of evidence is not evidence for absence, meaning just because there's not enough evidence doesn't mean we have to get a CT on everyone here at this point. So in this case, I would confirm delirium with a validated tool. I would treat the probable infectious triggers, looking for those underlying causes. I would optimize the environment, involve the family. They can certainly help reorient her, reassure her, calm her down. I would forgo immediate head CT unless there were any new neurologic red flags that emerged.
And then how are you going to take this new guideline and clinically apply it then in your practice?
Well, this is a guide, not a mandate. If your ED already has the staff and culture to screen broadly, then I think that's great. If you aren't already doing universal delirium screening, then these recommendations support a pragmatic approach. You could screen everyone for AT or DTS and BCAM, or you could use selective risk stratification for those patients who have underlying dementia, who have difficulty with ADLs or hearing impairment, or one of the other risk stratification tools, and then screen only those individuals. But doing something is better than just relying on Gestalt because we know we miss a lot of people with Gestalt. And the strongest practical move is probably not trying to choose the perfect tool, but choosing something that you can reliably and repeatably use in your department.
And then when it comes to imaging, I like this one because the key clinical takeaway is to exercise restraint in judgment, i.e., use your judgment. And the guideline does not endorse some blanket CT head that, hey, you're old, you're delirious, you get a head CT because you have a head. But it also says you don't never scan, right? You can still scan if you think you need to scan. So it leaves room for this selective imaging when there are additional red flags that, you might just pick up at the bedside. And of course, if they have trauma or focal neurologic findings, of course, we're probably going to send them over to the CT scanner. But it just highlights just how uncertain the evidence remains. That's a useful message for emergency physicians because it legitimizes what we're doing in the individual care of patients in decision making rather than just doing cookbook or checkbox medicine.
Absolutely. And finally, I would use these recommendations to try to tighten up the ED workflow around delirium. This is the start of the conversation, not the end of the conversation. And delirium screening only matters if it actually changes what happens next. It's not just a nice dashboard that we create that says, look, we screened 55% of people or 98% of people, and we identified delirium this number of times. What matters is then all those things that happen next, reviewing their medications, looking for polypharmacy, infection screening, hydration, mobility, sensory optimization, family engagement, safer disposition planning, all of those things that matter to the patient and that also matter to the healthcare system. Because if you can reduce delirium, you can potentially reduce inpatient length of stay. Guess what happens then? You open up beds so that you aren't boarding the next patient and letting them get delirious in the hallway. So the guideline is best used as one part of a delirium pathway, but not necessarily this is the be-all, end-all. And there are still many questions that I would like to see answered. So, dear listener, if you are interested in doing research, let's understand beyond just screening for delirium, what things can reduce incident delirium, meaning delirium that begins in the ED. What measures can prevent worsening of delirium to then reduce ED or inpatient length of stay, or reduce patient mortality, or reduce rates of discharge to a higher level of care? That's a surrogate marker for loss of function. So if you came from home, but now you're going to a skilled nursing facility, that's a big deal to the patient. And maybe if we reduce the rates of delirium, we could reduce that functional decline.
All right. Well, now we're going to talk about the Keener contest because it's been a bit. It's been a minute. We have to go back to episode 505. We've had a few episodes since. And no big surprise, Stephen Steltz out of Auckland, New Zealand knew that the most important physiologic mechanism used in non-invasive ventilation is upper airway dead space washout, which improves ventilation efficiency and reduces CO2 breathing. What's the Keener contest question this week?
The question for this week is, which delirium risk rule did the guidelines specifically say should not be used to identify low or high risk patients?
Well, thank you very much, Christina, for doing these back-to-back SGEM episodes. Clearly, you care about geriatric emergency medicine.
Well, I'm glad that you're platforming this work and getting it out there. Dissemination is one of the big keys in that, one of the most important links in that chain.
One of the things that's happened is some people, I think it was an Australian who reached out to us or something, that we connected with an Australian researcher who's also very interested in this area. And so made some nice connections already.
That's what it's all about.
Now, are you passionate enough to read the SGEM tagline as Lady Macbeth in a Scottish accent?
I do not think I could do that.
Oh, that would be a no.
That would be a no. I mean, could you do it?
Right.
Can you do? If you can do it, I might be able to copy it.
Remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.
Oh, I don't know. I don't think I can top that.
You just have to roll your R's.
If you could change your fate, would you do it?
Yeah, see, you could do it.
Remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.